Lucky for you, I can speak fast, and Lou had told me that I was going to be the bow on this package. I'm going to wrap up the final package, and then sitting in the audience today, pretty much everything I'm going to say people have said before, so I'm going to hit on the key points. So we don't need any objectives because we're not getting CE. I did, when I started this, I was putting some stuff down about myself because I don't know all of you, except for now looking in the audience, the majority of you probably work for me, and that's why you're still here. But others maybe don't know me. But I started out as I'm a nurse in pediatrics, EMT education, paramedic education. So as a paramedic instructor, I learned to talk fast and get to the point. And then I went into administration directors, and as I was looking at this, it's like, you know what, I used to be fun. I used to be fun when I was a paramedic instructor and so forth and so on, and then when I became a regulator and a director, I lost no longer so much fun. For Los Angeles County, the reason I put on here about all of Los Angeles County is because really all of the other counties kind of fit into Los Angeles County as a microcosm, so we're pretty much dealing with, you know, the rural, the urban, the big cities. We got an island that I'll show you in a minute. We have 4,000 square miles, over 10 million people, 33 public provider 911 agencies, 36 ambulance companies, 74 hospitals, 4,000 paramedics, over 600,000 calls a year, and we are big. This is a map of the county with our spas. This is where you're dealing with populations such as cities, beaches. We have a nice large rural desert area, and we have our island that we're dealing with. This is just showing, we had a big celebration, and we had every agency send 2 of their paramedics and the vehicles that they're on. So this is just showing the different vehicles that we're starting to come in on. We have bicycle paramedics now, SEADOOs, boats, helicopters. We have one department that would really like a mule team and horseback medics. So I don't have a picture of that, but when we get them, I'll take a picture. So my disclaimer is generally this is my perspective of community paramedicine as the director of a very large EMS agency. You know about our pilot projects. We had All Trans and the Compare project. This is a picture, a shout out to our paramedic, our community paramedic teams, and we did a presentation for them at our EMS commission. So for LA County, I will say that we are very, 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 very supportive of expanding the scope of practice for paramedics. It is time. We are excited about community paramedics. So, and then yay. So that is, we are the biggest advocates for EMS. Say it again, one more time, so they know. Yay. All right. So, oh, now I did it. Now, Lou, I'm not going to be able to get out of it. Let's see. All right. So, for anybody who doesn't know, paramedic program in EMS started in Los Angeles County. I think it's important to know your history before you plan your future. This is the first MICU mobile intensive care unit in the county, and it was McCormick Ambulance who owned it. It was donated by the Lions Club, and I think there's people in this room that remember Helm's Bakery trucks. It was an old Helm's Bakery truck, and that's Dr. Graff is there, and so that's starting up the first MICU in LA County in this California. When they started the paramedic programs, nurses had to go out with the paramedics and supervise them, giving the medication, starting IVs, etc., until we got the Wedsworth-Townsend Act in. 1972, the show Emergency started, and that was the takeoff for the paramedic program throughout the country. So some of the things I think Dr. Becker alluded to that we really haven't changed that much, and that's what these slides are for, since the beginning of paramedic program. But we have upgraded our ambulances. We're proud of that. We now have expanded vehicles so that we have paramedics coming in on bicycles, boats, helicopters. We have new defibrillators. We have new uniforms. So those are pretty much the big changes that we've had in our system for paramedics over the years. We have some other modifications, such as we now have these specialty centers, 12 EKGs, the nurse educators. Electronic data capturing is really in its infancy. And one of the things that I think is very, very important to the system that's occurring is the EMS boards and more MD involvement in our fellowship programs for EMS. Some changes have been CPAPs, capnography, interosseous. So Community Paramedic Pilot Project, this is the biggest proposed change that we've had since 1969. So 47 years it's taken us to have a significant change in our program. So the time is right in expanding our role in EMS. I have been in EMS for 25 years, 26 years now with the agency, and I've talked to medics and their attitude and how they felt of what they were doing was you call, we haul. And I've heard that earlier. And that's what they did. And we have talked about it being a transport mechanism and not a provider mechanism. So my other favorite quote is one significant fire chief in Los Angeles County. We actually hired him to help me understand the fire chiefs in LA County. And again, this is my perspective. And my perspective is all my fire chiefs love me. And so, but I don't understand them. I have a hard time understanding them. I don't know if there's fire chiefs in this room still. But one of the things that I said, I don't understand why they don't have EMS as like one of the most important things or higher up on their priority list, and understand how we can keep making changes and provide patient care and improve patient care. And he said, he goes, I'll tell you what fire chiefs think. He goes, I'll tell you what I think. He goes, I always thought no one's left dead in the street, so we're doing okay, right? And he really, and it's like, the light went on. It's like, yeah, that's what people think. Again, going back to the transport model. So society changes are impacting EMS right now. It's an exciting and important time to get into EMS, but it's also extremely challenging because of things we heard about here today. Higher behavioral health issues, homeless issues, drug and alcohol abuse, poverty. So it is very, very challenging and having a great impact on our EMS system. Data gives us the ability to identify, and the thing is, as Stacy just said, is very, very important. It gives us the ability to identify specific needs in specific communities and to establish our policies based on need. So data trends. I'm going to take you through a process where we're going to look at our general, big picture data and then kind of drill it down. We're not at the point yet, but we will be at the point where we can really drill down to specifics with public health. So to start off with, this is LA County's data. This is our trauma data from 2000. And if you can see the top, let's see. Anyway, okay, there it is. This is gunshot wounds are going down, so yay for that. This is some more trauma data, and if you look at the numbers on this, what do I want? Oh, there it is. Okay, what I'm looking at, this one's enclosed vehicles. This one with the triangle is falls. So over since 2000, if you look at our general data in LA County, falls are going up. We need to get to the point, and we are getting there. The more data you have, the more questions it poses. So why are people falling? Why has falls gone up so significantly? Auto versus ped has gone up. Is it because people can't remember how to walk? Is it because people are on their cell phones and looking at, trying to multitask and they're getting hit by cars? Why is it going up so significantly? So these are our general data questions and on our system data. So EMS is unique in that we have very specific data on communities. As our electronic data gets better, we will be able to drill down to where exactly these incidents are happening. Where are the falls? Are they at the same crosswalk? Are they in people's homes? Exactly who is falling? So we have data with the incident types, incident location, repeat incidents. And as also has been said over and over, we enter into people's homes and we see things that no one else has seen. EMS has the trust of the community. You go into facilities, they see risks. Things are just right there for the picking. There's so much low fruit hanging there that we can make a difference on. And then we can measure success and outcome. So community paramedic medicine could be driven by local needs. LEMSs really need to look at, and LEMSs are the local EMS agencies, they should look and assist cities to evaluate their data. Each city should use their data to determine the need for community paramedics. And I have a basic example of this. So I talked to our fire chiefs and I said, I'd like a volunteer for somebody to let us look at your data and develop a data report for you on your city that you can take to your city council and city manager and show what a great job you're doing. So City Z stepped up to the plate and said that we could use their data. So City Z is a fire-based EMS system. Suburban area, they have some industry, 21 square miles. They have 140,000 people in the city and 6 fire stations. So this is a skydiving lady. So let's see what the data tells us. And I was so shocked that this was so simple. This is a very simple thing. It can get more detailed as time goes on, but for a start, I think it's just perfect. EMS responses for this city has significantly gone up over the years, and they're now at 10,000 in 2015. We looked at their data by age and male, female. So right here, you see a huge spike. There's definitely more females. And then what is the age group right there? It's 80 to 90-year-olds. So it looks like this city, if you had to picture in your mind, it's probably a bedroom community with quite a few seniors. We looked at their medical chief complaints. Their top medical chief complaints, weak and dizzy. Second medical chief complaint is altered level of consciousness. Then we looked at their trauma patients. Their number one trauma chief complaint incident is falls. So what does that tell you that could be a possible need for this city, or what this city should be looking at with their community paramedicine if they had a community paramedicine program? What's low-hanging fruit for them to try to figure out what is happening in their city? Where are these, and as they could drill down their data more, they would need to look to see, are the falls all happening in the same community center? Are they all happening at the same convalescent home or SNF or assisted living home? Where are these falls occurring? Are they occurring out on the street? And how can they connect with somebody to do fall prevention programs in that city and track that data so that their city can see what a wonderful job their fire department is doing? And then again, when it comes to budget time and looking at programs, they're going to be able to get a program and funding from their city. In addition, I had to throw the CPR one in just because we have our sidewalk CPR program, and we're really trying to get bystander CPR up so we can get our ROSCE up. So with this city, they have, this is their cardiac arrest data by year. As you see, their bystander CPR, and part of it's a data capturing issue because the paramedics may not have documented the bystander CPR. Part of it is there wasn't bystander CPR. But their bystander CPR is pretty abysmal, and their ROSCE rate's pretty abysmal. We got them to start to participate and focus more on bystander CPR in 2014 and 15, and then in 16 they've done a really good job in CPR, bystander CPR training. So you can see that their bystander CPR rate's gone up and their ROSCE rate's gone up a little bit. So, I mean, if you took this to a city council meeting and you showed this increase every year in your productivity, in your citizens' safety, in your citizens, the health of your community, I just think that this data is so powerful, and it's so powerful at the system level, and it's also so powerful at the actual city community level. So this was the old lady falling, so that's my little joke for you guys, because that's the problem this city seems to have. just off the top of my head. So they would benefit if they had a community paramedic program. The beauty is that community paramedic having that additional education to be able to make these assessments, these connections, and work on a program. It's not that the fire chief has to go out and teach fall prevention, but they certainly could connect with the public health. They could connect with the university. They could have these connections to work on fall prevention for that community. And again, drilling down on the data to where specifically the fall prevention is needed. Repeat patients, encourage bystander CPR, getting communities to understand the importance of bystander CPR. So community paramedicine may be very specific to a community. It's something that's very powerful, will be very powerful. Or it can be general to the entire system, like having all the system being able to go to alternate destinations such as psychiatric facilities. Treat and release, I think we didn't have any treat and release projects. I think that's something that we should not ignore. Treat and release will be very good with community paramedics, again, with that extra education, very specific protocols, and to me, having aftercare instructions because it's a high-risk area. But now with the capability for video consulting, referrals, and aftercare instructions, I think that should be another program that we continue to look at. This is a sample of an aftercare instruction we did on animal bites. So if somebody had a sting or a dog bite or a minimum bite, they could get aftercare instruction to call 911 back or to go to this urgent care or to, if they have signs and symptoms of infection, to keep the wound clean, you know, those type of things. Alternate transport, we're all for it. Get the patient right to the right place for the right treatment that they need. Psychiatric urgent cares will be critical for us in Los Angeles County. Sobering centers as they come up, and it will be critical. General considerations for the program is we need to be careful not to take, to me, and again, this is my perspective, we need to be careful not to take on the hospital or the insurer's responsibilities and setting up unsustainable programs. If they need to see the value in it, they need to pay for it and not just take on the responsibilities of the hospitals. We had a lot of frustration with our programs trying to get some type of funding to sustain them. So maybe I'm a little bit biased on that, but I do think we need to be careful not to be altruistic and say, oh yeah, we can do this without having some type of sustainable funding. The focus, I think we need to focus on improving what EMS does best. And that is, as we've talked about multiple times, getting into the person's home, doing some education, and then getting the person to doing that appropriate assessment and getting the person to the right place. There are roles for community paramedics throughout the system for the individual communities, as I just showed you with City Z, and then more on a large-scale system such as alternate transport and treat and release. I always tell my fire chiefs, when you look good, we look good. So I think it's important that the local EMS agency, again, assists the provider with their data analysis, their data presentation, making connections in the community, coordinating data and provider agency efforts, and advocating for the provider agency with political bodies. This is my final farewell. Community paramedicine programs should be driven by data and analysis, and Stacy said it very well. You can't just try to set up a program when there's not a problem or an issue or there's no funding. You need to really look at the data and see what's needed. We need to recognize that each community has unique needs that would benefit from a community paramedic. What's needed in the Antelope Valley for us, or more rural areas, is not the same thing that's needed in an urban bedroom community versus Skid Row. So I think it needs to be very community specific. One size does not fit all. This is absolutely my final farewell tour. I feel like I'm a rock star. Let's not wait for the next 50 years to change the scope of practice for paramedics, and that's it. I think it would be a shame. I mean, the time is right now, so we need to do it. So thank you for your attention, and see if you have any questions. Oh, and thanks for staying. Thanks for staying, staff.